I'm really pleased to present our data on a combination therapy for steroid refractory acute GvHD to trying to prevent following chronic GvHD with a combination of ECP and ruxolitinib. Next slide, please. Maybe as a short background, as you all know, that the first-line treatment of steroid refractory GvHD are steroids. Still, unfortunately, maybe at some point in the next 5 to 10 years, this will hopefully change. However, responses due to that are probably around 60% in patients with lower grade GvHD, and especially these higher grade GvHD have less response, with approximately 1/3 of patients responding. As you all know, and I'm really looking forward to the discussion by Professor Mohty on quality of life, because I think this is a, what do you call it, stepchild or a foster child, is a factor that is not really taken into account into a lot of studies, but I think everyone agrees that GvHD is one of the biggest factors for reduced quality of life and morbidity in our patients. And therefore, there's a real need for really effective second-line, but also hopefully in the next few years, first-line treatment for these patients. You all also know that, thankfully, we have ruxolitinib approved in the US, but also in Europe for the treatment of acute and chronic GvHD in patients with an adequate response to corticosteroids or other therapies. And ECP is not yet approved, but is commonly used as a second-line therapy, especially in Europe, especially in the setting of steroid refractory GvHD. In the REACH2 trial, which investigated ruxo in patients with steroid refractory acute GvHD, ruxo led to significant improvements in efficacy outcomes versus control, especially a decrease in response rate was observed from day 28 to day 56, suggesting there is a need for improved long-term control of this disease. Despite the very promising response rates we saw in the REACH2 trial, a lot of patients lose their response. And as a result, there is a hypothesis to combine therapies to have maybe deeper responses or longer lasting responses. And there, for a pilot study previously published, showed a 2-year overall survival of 56% with tapering of steroids. Next slide, please. As a first highlight is that this is a retrospective study, so this comes with all the limitations we may discuss, and therefore has to be taken into account when interpreting these data. This is a study we did in our center, a single center study in Hamburg in Germany, where we investigated the combination of ECP and ruxo versus ruxo alone in patients with steroid refractory acute GvHD that have been treated between a period of 7 years until 2022 to allow for enough follow-up to analyze data. And we wanted especially to compare duration of response, but also efficacy on chronic GvHD incidence. The study design or the treatment was as follows. So patients received all ruxolitinib, and one cohort received a combination therapy together with ECP as a standard approach twice weekly for the first at least 2 weeks, followed by an individual reduction once per week over the next few weeks. Compared was it to the group that only received ruxolitinib, 10 milligrams twice daily, in addition to cyclosporin or tacrolimus. Ruxolitinib was then also tapered after remission, and ECP was continued to a total of 12 weeks in the combination group. The primary objective was overall response rate, including complete and partial response at day 28, but we also investigated GvHD relapse-free survival, chronic GvHD. Regarding some data on the treatment characteristics, the duration of ruxolitinib therapy was longer in the ECP and ruxolitinib group, approximately by a median of 77 days, versus only ruxolitinib group with 46 days. Next slide, please. There we come immediately to the efficacy. At day 28, the CR rate was higher in the ruxolitinib group or the ECP group. As you can see in the graphs, we have at day 28 a complete response rate in the ruxolitinib only group of 31%, while no patient achieved a complete response at day 28 for the combination therapy. And the total overall response rate was similar. But as you can see over time, that the response rate was a little bit more durable for the combination therapy and deepened for the combination therapy with 50% complete response at 6 months after initiating treatment for the combination therapy versus 40% versus ruxolitinib. Especially one thing that drove the whole comparison regarding efficacy was the cumulative incidence of chronic GvHD at 1 year, which was higher after ruxolitinib alone with 41% versus 24% for the combination therapy. Next slide, please. When it comes to survival, the combination therapy showed an improved chronic GvHD relapse-free survival benefit compared with ruxolitinib alone. And there was no difference in 2-year overall survival or non-relapse mortality between the two treatment groups. As you can see here in the curves, is that the chronic GvHD relapse-free survival for the combination therapy was 27% compared to only 8% for ruxolitinib. Next slide, please. And this brings us already to the key takeaways is, as you could see that the ORRs, so the overall response rate at day 28 and 56, were both 86% in the ruxolitinib group, which are in line with other reported real-world data. So this was very important to compare this with other data to see that the data are valid with the comparator arm. The initial higher complete response rate seen with ruxo compared with a combination therapy as the hypothesis could be due to increased proportion of high-grade acute GvHD in the ECP and ruxolitinib group. And this then could also maybe translate into the changes over time with deepening responses with the combination therapy. There was no difference in non-relapse mortality and overall survival. However, there was a difference in chronic GvHD relapse-free survival, but I must highlight that this composite endpoint was really driven by the incidence of chronic GvHD compared to ruxolitinib alone. Obviously, as I said in the beginning, we have to interpret this data with caution, single-center retrospective analysis. There might be factors, all the experts may know that ECP is quite a complex treatment compared to just a pill like ruxolitinib. So there are factors that delay initiation of treatment. And patients in the beginning had an imbalance of GvHD severity. So patients with ruxolitinib alone had higher rates of GvHD severity at the beginning. And therefore, there is a need for prospective randomized trial to confirm these data. And there are ongoing trials, especially within the MAGIC consortium, that especially evaluate the validity of a combination therapy of ruxo and ECP. And I think, is there another slide? But I think otherwise, discussion points, already probably announced. When should we treat patients with acute GvHD? What is the ideal time point? What is the duration? But especially also, what is the goal? I think this is one thing that is highlighted by the study. What are our endpoints that really translate into improved overall outcomes for our patients? Where should we look at? What should we deepen? In terms of treatment sequencing, which patients should we maybe choose for combination therapy? Should we think about trying to treat all patients with that approach or with combination approaches, or are there certain subgroups that may benefit from different individualized therapy? And how could ECP be utilized in that regard when we think about combination therapy for acute GvHD? And I think with that now, I'm done, and I'm really looking for the discussion. Thank you again for having me. Thank you.
Thank you very much, Nico, for very clear, nice presentation, and congratulations for the publication of this recent work in Hematologica. And this is, of course, a very welcome addition to the original report from Hamburg, which I mentioned in my introduction, although I made a mistake. I said a couple of years. Actually, it was older than this, December 2020. I think, Bipin Savani, you have already one comment if you'd like to jump in.
Just Nico, congratulations again. Very impressive data. Now, my question is, did you publish this information data?
Yes, we did just recently in Hematologica.
Okay, I didn't see the citation. That's what I was asking you. Yeah, thank you.
Okay, so let me try to structure this. And before going into the debate whether we should add or not ECP and how we should do it, my question, and I think we have Dr. Zeiser here because he led the REACH2 trial. Why do we feel, Robert, we need to add something to Ruxo or to bring something in addition? You may contradict Nico and say, no, Ruxo is doing great and we don't want anything else. So just give us a reminder, Robert, why this kind of combination is needed.
Yeah, as Nico already correctly said, there is a loss of response over time, and we would like to avoid that, right? Now, the loss of response is also due to the tapering of the other immunosuppressive drugs and ultimately also of Ruxo, which we also try to taper in our clinical routine. And yeah, I think addition of a therapy that is not very toxic like ECP is a smart idea. We have done the same in chronic graft-versus-host disease where we combined Ruxo with ECP, and we've seen better responses than with Ruxo alone. Also, this was not at all randomized, also just retrospective. I think it's a smart combination also because the mechanism of action is very different of these two interventions. I have no criticism. It should be tested, however, of course, in a prospective fashion, but that's also something that Nico already mentioned. In my view, there speaks nothing against combinations.
Yeah, thank you, Robert. And you alluded to the mechanism of action, and in the original report from Hamburg, there was some suggestion about the induction of Tregs. Dan, Dr. Wolff.
I would like to make one comment. So the problem is, as long as you don't randomize one versus the other ways, you can't be sure how much the combination adds. Where would be something which actually, Robert, you did, comparing a double agent approach with a single agent approach based on MAGIC risk group and say, okay, and using the MAGIC database, and how did a large sample of patients with the same risk profile failing and perform the Ruxo only versus the combination, given that the MAGIC high scorer have also not a low likelihood to fail on Ruxo mono. So that would be something which I would suggest to look at. And that could add some piece of evidence, indirect evidence at least, on the value of the combination.
Thank you, Dan. So assuming we all agree that ECP is a good candidate to be combined with Ruxo because, as it has been mentioned, it's relatively safe. There is, of course, the burden of coming in and out, and it needs to be done over several months or years. Now, the devil is always in the details. What would be the most appropriate schedule? So how to deliver ECP in these patients? And the second question, and I think Dan, you alluded to this, is that historically the common belief was that ECP is most active in cutaneous and mucosal localization. And obviously the steroid refractory acute GvHD in general do have a lot of GI involvement. So I can see Dr. Harris shaking his head. Maybe Andrew, you'd like to intervene?
Yeah, so I mean, through MAGIC, we've certainly shown that, you know, lethal, particularly GvHD, which is what we worry about most, almost invariably goes through the lower GI tract, which is the major issue for a vast majority of our patients. So I think that that's something that really needs to be always considered when we're discussing, you know, multimodal therapies as the added benefit, particularly for the lower GI tract.
So, Nico, can you comment on the schedule and how ECP was used in the study? Was it a homogeneous, was it an intensive schedule like every week? Sometimes I heard people doing twice per week. Or how did you manage it? Because I think, and you nicely alluded to the fact that there is no like label for ECP. It's more a medical device. So people would love to hear how, from a practical point of view, should I use it if I have to use it?
So yeah, thank you. So we do a completely standardized approach with a twice weekly start, at least for the first 2 weeks, if possible. I must say, again, if possible, because patients have to be eligible for that, come to the clinic, etc., have to arrive. But in most patients, I would say above 90%, this is easily done. And then we reduce it to once every week over the next 10 weeks. And then try to taper it down according to response.
But what criteria did you use to assign or not assign the patients in this particular retrospective look?
Just retrospective data where we said, okay, we do 50%, so in one patient this and one patient that. So no particular criteria to say to adjust or to control. This was just done on a day-by-day basis where we said, okay, we want to investigate this, and then just did it. And therefore, obviously, there are some characteristics that are different. As also Professor Harris said, interestingly, that patients with the combination therapy had higher rates of higher grade steroid refractory acute GvHD. But despite that, this could be one factor, that they have lower response rate at the beginning, and then, but still we see an increase on deepening responses over time. But this could be one factor, yeah.
I mean, I think we obviously have to look at baseline characteristics and MAGIC score and stuff like that. I'm certain that's included in the paper. Just out of curiosity, did you do this as a research study for those patients who you gave ECP to up front? I mean, that would not be considered standard unless it's standard in your center, particularly since you sort of randomly assigned some to get and some not to get.
Yeah, so this was in Germany. You sometimes can do if you have it and it's standard in your center, you can do it. So there was no particular research protocol. Obviously, we had to get a consent from these patients and tell them, based on our, as Professor Mohty said, initial results, retrospective data, we think that this is a valid approach. And then just assigned the patients to that. There were, in the patient characteristics, they were relatively well balanced. Only one thing was the severity of onset steroid refractory acute GvHD, which was different, but the main patient characteristics were balanced.
Wonderful. Thank you. Any other comments before I ask Nico the last question? Because you concluded with this, Nico, about having such a randomized trial, which obviously would be the highest level of evidence. I must confess, we've been struggling with ECP for the last 25 years or so. First report about ECP was 1987. So we're going to reach even more than 25 years. Well, it was in lymphoma, but still. How do you envision such trial and whether this is being planned?
I know there is a prospective evaluation within the MAGIC consortium. I would say what would be quite interesting, I believe from our data that clearly not everyone benefits from ECP. So like a biomarker adjusted selection of these patients, I think would be quite relevant, because we see that despite the higher severity of GvHD, these patients have longer lasting freedom from chronic GvHD. So I would suggest maybe that we try to combine this approach for higher risk biomarkers, depending on the MAGIC consortium data we have.
So would you feel comfortable telling a patient, we'd like to give you 2 therapies, so hopefully you'll be better in a year, with the understanding that the likelihood that you'll have a complete response in 1 month is 0? Whereas if you don't get 2 therapies, your your response rate is higher. Do you think this is necessarily a fair trade, without having seen mortality data and all of these other things, and second and third and fourth line data? Because I have to imagine if the CR rate was 0 at day 28 in the ECP plus ruxolitinib arm, some of these patients must have received other therapy.
Yeah, I completely agree. I would say that from a response statement, yes, but therefore I would say that we have to risk adjust it. So obviously not every patient should be evaluated for that. I would say that if you have higher risk patients where maybe the initial response rate is not the mainstay of endpoints, you want long lasting efficacy for these patients, I would say these would be candidates, at least in my understanding. Obviously, you're completely right. These data should not be used for trying to get this data or this treatment for everyone. Obviously, for that the data are too weak still, and therefore I don't know why this is. Maybe also the one problem is to do the study where response is limited, or where there are individual decisions to taper it off earlier for ECP. So even a standardized protocol for ECP is hard enough to establish.
Absolutely, and it's the most difficult part is to do it in a blinded fashion, because obviously the placebo with ECP can be very difficult. So no, thank you very much again. Congratulations for these great data showing a potential benefit of combining ECP plus Ruxo. I think this is work in progress, but this is really a very good start, and I'm sure based on this experience we'll see more and more of these experiences, and this is a very welcome addition to the field, especially that this is not only about CR and response, it's also about tapering steroids, and we all know the deleterious impact of high-dose steroids, but also this is about the PROs, the patient-reported outcomes and quality of life.